Gestational hypertension is a common condition that requires prompt management to ensure the health and safety of both the mother and the baby. The first-line antihypertensive in pregnancy-induced hypertension is labetalol, which is widely used due to its effectiveness and safety profile. Other options include methyl-dopa and modified-release nifedipine, selected based on the patient's specific needs and tolerance to side effects. Next, let us discuss the risk factors for gestational hypertension. Nulliparity, or being pregnant for the first time, is a significant risk factor. Women aged 40 years or older are also at a higher risk. A pregnancy interval exceeding 10 years between consecutive pregnancies can contribute to the development of hypertension. A family history of preeclampsia is another crucial factor to consider. Multiple pregnancies, such as twins or triplets, increase the risk due to the additional physiological demands on the body. A body mass index, or BMI, of 35 kilograms per square meter or higher also elevates the likelihood of gestational hypertension. Early gestational age at the time of presentation is another red flag, indicating the need for careful monitoring. A previous history of preeclampsia or gestational hypertension predisposes women to recurrent issues in subsequent pregnancies. Finally, pre-existing vascular or kidney disease adds to the complexity of managing hypertension during pregnancy. Understanding these risk factors and management strategies is essential for providing comprehensive care and improving pregnancy outcomes. Management of pregnancy with gestational hypertension varies based on the degree of hypertension: mild, moderate, or severe. Let's go through each category. For mild gestational hypertension, defined as blood pressure between 140/90 and 149/99 millimeters of mercury, hospital admission is not required, no treatment is typically necessary, and the focus is on regular monitoring. Blood pressure should be measured no more than once a week. Testing for proteinuria is performed at each visit using automated strips or a protein-creatinine ratio. Routine antenatal blood tests are sufficient unless other concerns arise. For moderate gestational hypertension, with blood pressure ranging from 150/100 to 159/109 millimeters of mercury, hospital admission is also not necessary. However, treatment with oral labetalol is recommended to maintain diastolic blood pressure between 80 and 100 and systolic blood pressure below 150. Blood pressure should be measured at least twice a week. Proteinuria testing is done at every visit using automated methods. Additionally, blood tests are conducted to evaluate kidney function, electrolytes, full blood count, transaminases, and bilirubin, with repeats if proteinuria is detected. In cases of severe gestational hypertension, defined as blood pressure at or above 160/110 millimeters of mercury, hospital admission is mandatory until blood pressure is controlled and falls below 159/109 millimeters of mercury. Treatment includes oral labetalol, aiming to maintain the same target blood pressure levels. Blood pressure must be measured at least 4 times a day. Proteinuria is tested daily, and blood tests are performed at presentation and repeated weekly to monitor kidney function, electrolytes, full blood count, transaminases, and bilirubin. It is important to note that hospital bed rest is not recommended as a treatment for gestational hypertension. For severe gestational hypertension that has been controlled in the hospital but is being managed as an outpatient, ongoing monitoring is crucial. Blood pressure and urine should be checked twice weekly, and blood tests should be repeated weekly to ensure stability. These guidelines provide a structured approach to managing gestational hypertension, focusing on both maternal and fetal well-being. Please like and subscribe to TuringMedSchool. Good luck with your preparation.